Hello, and welcome to Opt to Thrive, episode 26, Navigating Endometriosis, from diagnosis through to menopause, what you need to know.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
Welcome back. I have found my way back to the sunroom. It is a spectacular autumn day, so we're just kind of getting into some autumn weather now. The sky is spectacularly blue. There's a little breeze out there. I've got the sheets on the clothesline, and they're, what do you call it, wafting? Wafting away on the clothesline. Sheets on a clothesline in the breeze. There is something about it that just makes my heart happy. I don't know if anyone else feels that way, but it just reminds me of a relaxing weekend day, I guess. Maybe that's why I feel that way. We got some beautiful winter blooms going on out there in the garden. I've got some rosemary, the little daisies. I've just planted a new daisy bush because I killed a little one that I had planted kind of earlier in the summer that didn't make it through some of those 40-degree days, unfortunately. But yes, it's looking beautiful out there. I've done my Sunday morning ritual ride and swim. The water's getting a little bit brisk. When you jump in it, it's a little bit brisk, but you're in there a couple of minutes and then it feels really quite nice. The water was like glass today, so really, really enjoyable. And then, of course, the coffee afterwards, it just can't be beat. The coffee tastes so much better after you've worked your body. I did spend some time last week unwell. I'm not sure exactly what it was, but it did put me out for a good couple of days, and I missed a couple of my gym sessions. I did pull up on Friday morning to go to the gym and parked the car and thought twice. I just didn't feel like I was quite ready to get back into it yet. I just felt a little bit nauseous and quite tired still, so I thought it better just to go have coffee with the girls. My girlfriends do a lot more swimming than I do, and often will be swimming bright and early on a Friday morning. So I caught up with them before I got started with my day and had a coffee, and then I did the gym on Saturday, which is a bit different for me. It was nice. There was only a couple of people in there, and I just slowly got back into it, which is, what we recommend. As a GP, I would recommend to my patients just slowly kind of getting back into it. Certainly don't get back into the gym if you still have a fever. You want to wait till your symptoms have passed and then slowly get your way back into it. The important bit is just getting back into it, right? Just making a move. So I cut all of my weights back by a good, I was going to go 50%, but I probably went more like 75%. I cut them back by like 25%. And I felt really good after. And then I got on the bike this morning and we smashed it out. I had a really good ride and a good therapy session, as always, with the girls. So here we are, back at it. And today we're going to talk about endometriosis. Now you might be wondering, a midlife podcast, why I would be talking about endometriosis, because it's generally something that tends to affect us as we're going through our reproductive years with our menstrual cycle. And at midlife, that's one of the things that stops. But I would imagine that we have a lot of listeners that are probably still within the cycling of their menses. And also I had some thoughts about, a lot of us have daughters and, has this crossed your mind? Could they have endometriosis? So I really wanted to get some education out there, because what we know is that it takes on average 7 years for a woman to get the diagnosis of endometriosis. And there's some reasons for that. We're going to talk about that today. Since about 17, 18, endometriosis has gotten a bit of attention in the media and within the government. We've gotten some government funding over that time. There's been a lot of work in getting some specialized clinics organized for women to be seen to, with the hopes that we can get this diagnosis a bit earlier. rather than having a woman wait for 7 years. It can be a very debilitating condition. These women can really suffer. So 7 years of suffering and quite possibly not being managed well can take its toll on a woman, not only her mental health, but if this condition isn't managed properly, it can have some repercussions. So let's dive in, shall we? So what is endometriosis anyway? So endometriosis is when there are little deposits in usually the pelvis. That's the most common place, but could be around the abdomen. We'll talk about all the different places it can implant. But these little deposits of endometrial-like tissue. So the endometrium is the lining of the uterus, and it's that same type of tissue that deposits itself around different areas. The most accepted theory is that when a woman has a period, the lining of the uterus is shed and comes out of the uterus through the vagina. And the most common theory is that some of that tissue finds its way out into the pelvis or the abdominal cavity through the fallopian tube. So we call that retrograde flow. So it's actually flowing backwards and out of the tubes. Now, that can't be the only reason, because we would all have it if that's the case, right? Everyone who menstruates would have endometriosis. So there's got to be some other factors at play. We know that there is a genetic component, and we believe that there's some kind of an immune component as well. So it's not totally understood, like many things in women's health. So these little deposits are most often found in the lining of the pelvis, on the outside of the uterus, the fallopian tubes, the ovaries, the ligaments that hold the uterus in place within your pelvis, the bowel and the diaphragm, the bladder, and the tubes that run from the kidneys to the bladder. It can also grow into cesarean scars and the abdominal wall. And if you've ever had a laparoscopy, those little scars. So it can just kind of implant in all these little places. And because this tissue is the same kind of tissue that's in the uterus, each month as you have the hormonal fluctuations that happen around that time of the month, the tissue is stimulated in much the same way that the uterine tissue is stimulated, right? And this causes inflammation and pain in all of those places that it has implanted. It can also cause scarring. Now, depending on the source that you read, somewhere between 1 in 7 to 1 in 10 women of reproductive age have endometriosis. So somewhere around 700,000 women in Australia are affected. It's most commonly diagnosed around kind of 30 to 34 years old quite often. And as I said in the intro, it can be debilitating. So the most common symptom of endometriosis is pelvic pain. It can be mild all the way through to severe. In some cases, women have no symptoms at all. The pain usually occurs during menstruation, but it can become non-cyclical as well. Women could have pain with intercourse, pain with moving bowels or wean. Often they can complain of fatigue, so being really tired. Now, fatigue can have lots of causes, but about half of those with endometriosis will report having it. And it can cause trouble with getting pregnant. So it is a cause of infertility. They can also get heavy menstrual bleeding or bleeding between periods. That's definitely not diagnostic. That can be other causes, and it certainly needs to be further explored with your doctor to see if there's some other investigations that need to happen just to make sure there's nothing else going on. Most women with endometriosis do not have abnormal bleeding. There can also be digestive issues like bloating or diarrhea or constipation and nausea, especially around menstruation, so those cyclical kind of symptoms. When I was doing some research for this talk, I found an article on something called the endobelly. It's described in the literature, but it's not validated, meaning that it's not yet accepted or recognized by the medical community as a condition, but it certainly makes sense to me. If you had deposits on the bowel, how that can impact your bowel. And certainly something to take note of if you're having cyclical bowel issues and to take to your doctor. So why does it take so long to make this diagnosis? Okay, so there's two types of dysmenorrhea. Dysmenorrhea is the medical term for painful periods. There's primary dysmenorrhea, meaning that there is no cause. It just is what it is. And we know that over half of young women are going to have typical period pain. So primary dysmenorrhea. Typical period pain usually starts with the period and is worse over those first couple of days. Usually those are the heavy flow days. And the pain is typically in the lower pelvis or in the lower back. But when is period pain more than just period pain? When is it secondary dysmenorrhea, meaning that it has a cause? There's something causing this pain other than just the period itself. That can be a really tricky question. We all have different pain tolerances for one, and unfortunately, going to the doctor and complaining of period pain can often be minimized and normalized. So, what should we be on the lookout for to make us consider endometriosis as a diagnosis? There are a few red flags that should be getting our attention, and if this is you, these are the things that you need to be telling your doctor. Now, if your period pain is affecting your daily activities and or your quality of life, so are you missing work or school or skipping social functions due to the pain? These are red flags. Cyclical symptoms like pain with moving your bowels or voiding is another one. Once there's suspicion then that it could be endometriosis, how do we make the diagnosis? The first thing as a doctor that we need to be doing is taking a really good history, and then the second thing is doing an examination. A pelvic and abdominal exam might show some signs, but most often they don't. Probably the best chance of finding something on an examination is if it's done while the woman is menstruating. Part of the examination would be also to look for other causes of pain. So a cervical screening test, having a look at the cervix and taking a sample from the cervix. That sample could also be looked at for chlamydia, just to exclude that as a cause. Swabs can be taken also to look for other infections that could be causing pain. It's most likely that a urine sample will be collected to look for a urinary tract infection. And then the next step would be an ultrasound. Now, I'm going to warn you, if you haven't had a pelvic ultrasound before, most likely it's going to be a transvaginal ultrasound. Unless you're a woman who has not been sexually active previously, then it's not standard practice to do a vaginal ultrasound. But a vaginal ultrasound is often the best way to see a lot of those structures in the pelvis. And in order to pick up endometriosis on an ultrasound, it is very difficult. In fact, if it's possible, it's best to have these ultrasounds done by a service that is specialized in picking these kinds of things up, and in particular, a service that is specialized in women's health. The very best chance of picking it up on ultrasound is if it's affecting the ovaries, something called an endometrioma, so a bit of that tissue growing on an ovary. Now, if the ultrasound has been reported as normal, it doesn't necessarily mean that there isn't any endometriosis there, because as I said, it's really hard to pick it up on ultrasound. So is an MRI any better? Might be an option for specific types of endometriosis, but it's expensive. Not everyone has access to an MRI, and at least here in Australia, that's going to need a specialist to make that call. CT isn't helpful, and there are no blood tests that can tell us either. So the only way to really know for sure if someone has endometriosis is by actually visualizing it. And the gold standard is actually visualizing it and getting a positive biopsy result. The way that this is most often done is by a laparoscopy. So that's where they make the little keyholes in the abdominal wall and they stick a little camera in there, and they can have a good look around all through the pelvis and see if they can see any of the deposits on anything in there. And when they do see them, they can take a little biopsy. Now, not everyone is going to need a laparoscopy because obviously there are risks involved with such an invasive procedure. So we generally try to avoid it if we can. We can make a clinical diagnosis, or what we call a working diagnosis, meaning we've excluded those other causes that we've talked about for the symptoms, and we've made the diagnosis based on that exclusion and because the symptoms fit. So if we're pretty confident in the diagnosis, we generally just treat it. So let's talk about treatment options. First, let me preface this discussion around treatment options by making it clear there is no cure for endometriosis, unfortunately. Even if we go in and we try to cut it all out, it's very likely it's going to recur. And in fact, going back in surgically after you've already had this done previously is associated with an increased risk of worsening pain and reduced fertility. So we really try to avoid doing it more than once. And often that once is because either it hasn't improved with the treatments that we've given a woman, or she is having trouble conceiving. And in that case, the laparoscopy can help improve her chances of conceiving. So generally, first line treatment for endometriosis is pain relief. And we generally start with an NSAID, a non-steroidal anti-inflammatory drug. The most common ones would be ibuprofen, naproxen, or mefenamic acid. So all of those are over the counter. Important to note, anti-inflammatories can cause gastric irritation, so irritation of the lining of the stomach. So if you're getting heartburn or reflux, then these are not the medications for you. Paracetamol is another option. The anti-inflammatories work on a couple of mechanisms that help with the pain. They are better if you can tolerate them, but paracetamol can be effective as well. The next thing we usually recommend is some kind of a hormonal treatment, unless you are looking at conceiving. Because those little tissue deposits are stimulated by estrogen, then we can manipulate the estrogen levels in the body to manage the stimulation of those tissues. The easiest way to do this is through some type of a contraception. The standard pill has both estrogen and progestogen. And the way that I like to explain the mechanism of how it works in the body is that it kind of hijacks the body's usual menstrual cycle, and it doesn't allow ovulation, so no egg gets released for fertilization. When a woman takes the pill, her usual fluctuations in hormones don't occur because the menstrual cycle has been hijacked, as I said. And so those little tissue deposits then aren't being stimulated in the way that they would be if those fluctuations were happening. The other hormonal treatment is with a progestogen itself. So a progestogen is a molecule that behaves the way our body's own progesterone does. So this can be with a progesterone-only pill, the Implanon, which is the implant or the bar that goes in the arm, and it secretes a progestin continuously into the body, or the Mirena intrauterine device, which also secretes a progestin directly into the lining of the uterus. There are different progestins between the Implanon and the Mirena, so they do work a little bit differently than each other, but essentially they suppress the function of the ovary and they reduce estrogen levels in the body. So again, those little deposits aren't getting stimulated. They also lower inflammation and they can shrink the size of the endometriosis. So which option's best? Well, whichever one suits you the best, really. The only caveat here is that there is some suggestion in the literature that the combined estrogen and progestin pill may not be quite as good as the progestogen-only treatments in preventing recurrence, which we're going to talk about in just a second when we talk about what they actually do with that laparoscopy that we were talking about a little bit earlier. Now, I just wanted to touch quickly on Chinese herbal medicine and supplements and whether or not they're helpful. There is no evidence that they're helpful. In fact, there are some concerns that they can actually be harmful. There is some low to moderate level evidence that acupuncture might be helpful. Don't know. Okay, so let's say we've tried the NSAIDs, and we've tried the hormonal treatment, but we haven't been able to manage the pain. Then what? Well, that means it's time to go see the gynecologist and talk about having a laparoscopy. Or let's say, as I said before, you've been trying to conceive and you haven't been able to fall pregnant. That's the other time when a laparoscopy is going to most likely be recommended. So what happens when you have the laparoscopy? Well, the surgeon can either excise the lesions or destroy them with ablation, either with a laser or electricity. As I mentioned earlier, endometriosis does tend to come back. The rates of recurrence I found in the literature was somewhere around 21.5% will reoccur at 2 years and 40 to 50% at 5 years. Recurrence tends to be more common in younger women, in women who have more advanced endometriosis, and if they've had adhesions, which is scar tissue caused by the endometriosis, and also women who have a high BMI. Now, what if you decide that you'd just rather have it all out? You'd want a hysterectomy, just get rid of it. Unfortunately, about 15% of women continue to have symptoms even after they've had the hysterectomy. And even worse, somewhere between 3 and 5% will have worsening pain after they've had a hysterectomy. What about pregnancy? Does getting pregnant or breastfeeding help endometriosis? Unfortunately, there's no clear evidence that they do. Pregnancy doesn't cure endometriosis, but symptoms often improve because you're not having periods during pregnancy, so you don't have those hormonal fluctuations that you get with your normal menstrual cycle. There are some women who do continue to have pain throughout their pregnancy, but most women with endometriosis do go on to have a normal, uncomplicated pregnancy. Some women find that their endometriosis symptoms improve or go away after giving birth, but for many women, endometriosis symptoms come back after they stop breastfeeding and their period has returned. I wanted to mention an important risk associated with endometriosis that's been a little bit more in the literature in the last couple of years about a slightly increased risk of developing certain types of ovarian cancer in women who have had endometriosis. The risk seems to be a little bit more if they have had endometriosis on an ovary. So it's important to just have this in the back of your mind if you do have endometriosis, because the doctor will definitely need to take that into account if you had something like an ovarian cyst or some kind of a mass that needs further evaluation. That's going to factor into how they investigate and manage that. Now let's put it into context. The lifetime risk of getting ovarian cancer is somewhere between 1.8 to 2.4%. So it's a low risk, but it's important, as I said, to point it out so that we can keep that in the back of our mind when we are evaluating other symptoms that might occur in your lifetime. Now I want to tie this into how it fits in with menopause. You might be wondering, what happens to endometriosis after menopause? Surely we don't have to worry about it anymore if it's the estrogen that's causing the problem. And now we're running a bit low on estrogen, aren't we? The good news is that yes, for most women, endometriosis pain does improve after menopause, but a few women are still going to have some symptoms. The numbers that I found quoted in the literature was somewhere between 2 and 5%. And then there could be a chance that the endometriosis symptoms are reactivated by hormone replacement therapy or menopause hormone treatment. And this is especially true if they are just getting estrogen. So the recommendation for women who have had endometriosis before menopause and they're wanting treatment to control their menopausal symptoms is to use a progestogen estrogen combined therapy in a continuous formulation. So not the cyclical formulation where you have 2 weeks of the progestogen and 2 weeks without the progestogen. One of the reasons for this recommendation is that there is some concern about the development of cancer in these little deposits if we use the estrogen-only hormone treatment. Much in the same way that we need to give the progestogen to protect the uterus in a woman who has a uterus over those who have had a hysterectomy and can have just the estrogen without the progestogen. So in this case, we need to protect those little deposits by giving them both the estrogen and the progestogen. So in a woman who's had endometriosis, just so that I'm clear, even if she's had a hysterectomy, the recommendation is that she get both a progestogen and an estrogen. And just one more little tidbit of information, something that I found very interesting that I had not heard before when I dove a little bit deep into the topic, was that endometriosis has been associated with an increase in cardiovascular risk. Not something that I would have considered before. It's a bit of an interesting mechanism. So endometriosis is thought to cause systemic inflammation, so inflammation throughout the body, and endothelial dysfunction. Endothelium is what lines our blood vessels. So it's thought that this inflammation and endothelial dysfunction can predispose to atherosclerosis, which is the plaque buildup in the lining of the blood vessel. So something to keep in mind when we're looking at long-term risks. As I have said time and time again, one of the risks that happens for us after menopause is that increased risk in cardiovascular disease. So just being aware that endometriosis can add to that risk. So there you go. That's endometriosis in a nutshell, somewhat. So to summarize, endometriosis is a chronic condition where there's tissue similar to that lines the uterus, is growing outside of the uterus. It causes pain, can cause infertility and other symptoms. Though we don't quite understand exactly what the cause is, there are treatments that can help manage the symptoms and improve quality of life for those women who are affected. It's really important that we recognize the signs of endometriosis and we seek a proper diagnosis and get some treatment, as we know that early intervention can make a big difference. So if you or someone you know is experiencing these symptoms and you have not had a diagnosis or have not had it looked into, please chat with your doctor about it. I hope that you have enjoyed this episode, a little bit different in that it's not specifically midlife necessarily, but something that I think is very important, as I said, can be quite debilitating for some women. And even just to have an understanding of what some other women are going through can be really important, I think. So if you can think of someone who might benefit from this episode, please pass it on, as always. And don't forget to rate and review the podcast so that it can be visible to others who are looking for this kind of information. I hope that you all have a fabulous week wherever you may be. And until next week, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts for medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.